Hi there, I'm Dave Dennis, Medical Services Officer with Tualatin Valley Fire and Rescue. I'm joined today by Dr. Daya.
Hi there.
We are going to talk about a new medication in this year's protocol, in the 2018 protocol. We're going to talk about Ketorolac.
Correct.
So it's a non-steroidal anti-inflammatory. And if you want to talk a little bit about some of the mechanism behind it.
Right, so Ketorolac is like ibuprofen. The only difference is it's basically a parenteral or form that you can give either intravenously or intramuscularly. It's a very potent agent, works super well, and it's a nice drug that we use for its anti-inflammatory analgesic effects. Most of these drugs work by knocking out something called prostaglandins, which are a mediator of pain in your body, and that's how they work. They're used a lot. Ketorolac is used a lot for musculoskeletal back pain, inflammatory pain of that nature. But it's also a great drug, interestingly, for kidney stone pain, because a lot of kidney stone pain is related to prostaglandin release in your kidneys because of the blocked ureter. So those are the two areas that you'll see a lot of its use. And the nice thing about it is that it gives you an option to give something IV or IM that's not a opiate type agent.
Right, and we'll talk about that. So we brought this up to the Protocol Development Committee. We were looking for a couple different options. You know, we asked ourselves three questions. Are we managing pain effectively? Are we managing risk appropriately? Because controlled medications are inherently risky in themselves. Right. And then are there ways to manage both? So as you can see, I mean, we have some other options out there, but we didn't have anything quite like Ketorolac before.
Correct.
And this has been in the headlines recently. You know, there is an epidemic about opiate overdose, especially in Oregon. And that was, you know, part of the consideration as well.
So this is a national issue. Everybody thinks that prescribers prescribe too much opiates, and that's unfortunately our main go-to for pain relief today. Now we've added a few agents such as ketamine, and now we're adding Ketorolac. Ketorolac's been actually around since the 90s. It's not a new drug by any means. The only difference, I think, is that it was a drug that was non-generic. Now that it's generic, it's much cheaper, so it's much more affordable for our EMS systems to use it.
So we actually took a little snapshot when we were preparing our presentation. We looked at a 10-year snapshot here at TVFNR about our fentanyl administration. So as you can see, I mean, it increased dramatically. Just get, I mean, we're treating pain appropriately.
Well, I think that part of that increase is because we allow the intranasal route, which is a
Right.
much quicker way to give the drug, and it works pretty fast. So, but I think in general, you know, in the early 2000s, most EMS systems and emergency departments were criticized for what was called oligoanalgesia, not giving enough pain medicine. So what happened? The pendulum swung the other way. I still think you treat pain, but I think it's nice to have what's called a compendium, a bunch of options to give, because not the same thing should work on everybody, and each of these drugs works differently. What's interesting about opiates is they work on your brain to change your sensation of pain. The beauty about the drugs such as acetaminophen and Ketorolac is they're actually working locally to change the local pain signaling. So in many ways, I think they're more effective.
So here's a look at the protocol here. So this is, like I said, a brand new protocol. We're going to have an IM or IV route for this. So it's 30 milligrams IM or 15 milligrams IV. It's going to be a one-time dose. We're not going to repeat it. After that, I mean, you can certainly then follow that up with the fentanyl if you want to.
And there's no reason why you can't give fentanyl together with this. I think, for example, with kidney stone pain, it's nice to give a combination, and there's a good study that shows a combination is better than either drug alone.
Right. And it is appropriate for kids as well, as long as they're over 2. We'll talk about the contraindications here, which there are a number of them, which inherent with non-steroidal drugs. If you want to talk a little bit about some of these contraindications.
So when you change your prostaglandin synthesis, you also basically knock out your platelets and you make them dysfunctional for a period of time, usually 24, 48 hours. And so unfortunately, you don't want to knock platelets out in someone who's got any kind of bleeding risk, such as liver disease, someone who's basically actively bleeding or has any kind of ulcer. It's also not a great drug to give for someone with chest pain, because basically the aspirin is then competing with the Toradol, and aspirin actually knocks the platelets out for a lifetime, which is 7 days, as opposed to the Ketorolac, which is much more shorter time. So as a result of this, there are a few contraindications. Probably the biggest ones, I think, are to remember. One is under 2 or greater than 64, because in both of these cases, there's often some element of renal risk to the individual, and so we don't want to be giving it to those individuals because they might have some decreased kidney function. Secondly, if they have known decreased kidney function or kidney transplant, they shouldn't get this. And then everything else on this is largely looking at people who have any kind of bleeding or bleeding disorders or bleeding diathesis, such as being on an anticoagulant. So that's the group you want to avoid this to. The ideal group for me are patients who have, like, I lifted something, my back hurts. That's a great, person to potentially consider it for. Or someone who has pretty significant flank pain and it sort of fits with writhing around, intermittent, in the right age group, or history of kidney stones. That's a good, And some of these patients who have renal colic and have called 911 and they've had kidney stones before will tell you that Ketorolac works very well, and they may even ask for that drug. The last thing to remember is that opiates are actually now such news items in our society that many people decline opiates for pain. They actually will say, I don't want any opiates. I don't want fentanyl. I don't want morphine. And so this is a good option for them if they meet the indications as well as the contraindications. So the contraindications are in the red in the slide. Please spend some time looking over them.
So just some final take-home points. We talked about Ketorolac not being an opiate. It's not habit forming. And then combined with fentanyl, we talked about, actually can be very effective, especially for renal colic. Again, the dose being 15 milligrams IV or 30 milligrams IM. And just remember, there is an age range there, so 2 to 64 years of age. And don't forget, you also have ibuprofen and acetaminophen in the protocol, and that can be used as an oral pain medication
right.
option.
Obviously, I mean, the sense is that if you're going to Ketorolac, you're looking for an IV or IM option, because it's easier if you've got ibuprofen. You shouldn't give both Ketorolac and ibuprofen. That doesn't make much sense, because they're the same category of drug.
All right, well, thanks for watching, and remember, these protocols will take effect on January 8, 2018. Thanks.
Thank you.